Okay, awesome. I think we're good now. Okay, well, thanks again. Welcome everybody, also to the people online. Please shout if you don't hear and see us, then we try to fix it again. So as said, my talk is to give or not to give. And this concerns blood and organ donation, and it of course concerns donors. So why do people give? Why do people not give? And when do they do this during their life course to help strangers, often repeatedly, because blood donors give to strangers in many countries in the global north. In the global south, we also have a family replacement system, which is very common there. So people have to bring their donor if they want to get treated. So there you would know the donor, but in our global north settings, often you give to strangers. And people come with different motivations, different considerations to donate. And sometimes it can incur high personal costs, right? Because you have minor medical risks for blood donation, but when it comes to a living organ donation, costs can become very, very high and even go as far as a surgery or a treatment with growth hormones if you want to donate stem cells. So costs can be differently and can be very high. A blood donation is less costly, but still you have to make an effort. You have to go to the collection center. You have to report. You have to bring time and so on. And the interesting thing is that people do it. And now I'm trying to understand why people do it, because it's not so many people who do it, right? So in Western countries, the active blood donor population is around 2 to 3% of the adult population, which means there's a high degree of free riding, right? So everybody, or almost everybody, wants to get treated once they need a blood unit or a platelet unit or a plasma-derived medicine. But the people who donate to make these products available are very, very few. So the large majority relies on a very small minority. So there's a high degree of free riding in human substances donation. And we are trying to understand why and also what makes people donate. So I understood there are a few donors here. So David is one of them. Would you mind telling me why you donate?
I don't really.
You don't know really? That's a good thing.
Well, I'm negative.
Yeah,
so
okay.
High demand.
High demand. So you're very, very wanted.
Yeah.
Yeah. Yeah. So I think that's an interesting one. So you're wanted. People, especially donors with O negative blood, they are invited more often in many countries. They are treated better than the B positive ones. You know, I mean, I'm exaggerating, but they are invited more often. They are also receiving this letters. You're very valuable to us. You can save many patients because you have this this O neg type. Any other donors? Yeah. Would you mind telling us why you donate?
Well, I was peer pressured.
Very good, very good. Yeah.
And I kept going back because of this refreshment.
Awesome. Thank you. So this is another very often mentioned motivator. I know other donors. And then, for example, or a patient, so someone has been treated with a blood product. So you realize, you become aware of the need that someone has to also fill the stocks again. So we try to group donor motivations in different categories. And so if you ask people why they donate, they often come with more altruistic reasons, such as I wanted to help, I wanted to contribute. But there's also social reasons, as we just heard. I was peer pressured, or I knew another donor, I knew a patient. And then there's also what I call, with a question mark, more selfish considerations, because people tell us also about the warm glow they experience after having made a donation. So you feel good, you feel better, you contribute, and your blood is wanted, so that gives you a good feeling. And there's been in the literature, this has been described across disciplines, so in economics, in sociology, in psychology, why people donate, and it's often a very it's often monodisciplinary approaches. So economists look at external motivators in relation to intrinsic motivation. Sociologists tend to try and understand behavior on different levels, like individual motives, but also how the social structures in which people make donations play a role, such as how is the blood supply organized? Do they provide incentives or nice refreshments? Is the collection site nearby? Is it easy to get there? So more practical reasons. And psychologists, you know, they understand more the personality or value motives. And when you look at these motivations that have been broadly described in the literature, you can again see how there's a more altruistic group and then a more social group. For example, what we call reluctant altruism refers to whether people think there's enough blood, and if you think there's not enough blood, you feel responsible to provide your own share. So you fill the stocks because you don't trust that there's enough once you might need to be treated. Image motivation has been described. So people do good things because they want to increase their reputation. They want to show off in a way that they are good people. So that can, and then of course you can have a combination and an interplay of all these different motives. So as I said, I have a background in sociology, so I try to understand cultural implications and factors as well, and that's often different across countries. So we try to compare also countries, and here with this study, we look at Europe and how people have a history of blood donation. That's what you can see on the left-hand map. So the darker the color, the less people have a history of blood donation. So this goes from a low, it's not even that low, but 24%, for example, in Portugal have ever donated blood, but that goes up to more than 50% in Austria. So 50%, more than 50% in Austria have ever donated blood. That's a huge part of the population, but again, that's in a lifetime, and the active donor population is still small and it's concentrating around 3%. When you look to the right-hand map, you see we asked people with the Eurobarometer. It's a relatively old study, but it's commissioned by the European Commission, and in this survey, people were a representative sample of the European countries were asked whether they were prepared to donate blood in the future, so whether they would consider becoming a blood donor in the future. And there you see, again, large variation, but high proportions of the population say, yeah, I would become a blood donor in the future. So then the big question is, of course, how can you convert these people to real donors? Because it might be partially social desirability bias. People say, of course, I want to be a blood donor, but then when it comes to the very behavior, there might be many barriers. So it is important to understand how the intention becomes a behavior, and how also with more applied marketing interventions, you can nudge people a bit. And in the same study, we also asked people who had a blood donation history, so those who were donors we asked them why they were donors, what motivated them, and here you see back our motives we've already discussed: help people in need, help family, alleviate shortages. So here again, if you think, oh yeah, there might be not enough blood, I contribute my share. And then interestingly, we also have this more personal factors, that people have a history of knowing blood donors or knowing patients, and also they want to receive a transfusion themselves if they needed one. So this is a very strong manipulation. Also, if you ask people, would you like to receive a transfusion if you need one, and you say yes, and then you ask people, yeah, why would you not become a donor? Because blood has to come from somewhere. So, and another interesting factor is what we call perceived safety. So also more trust in the healthcare system. Would you think that receiving a transfusion is safe? Would you undergo it? That motivates people to become donors as well. So to conclude this first study, when you ask people, they are prepared to donate or they have donated, and come or report pro-social motives, and also more transfusion-related and blood service-related motives. But as I said, this is a self-reported survey answer. So the question still remains: can we bridge the intention behavior gap here? So therefore, we need more experimental work, and I'll show a bit of that in a minute, and also more specified questions about which, about, for example, incentives. This is a very hot topic, always has been, because in some countries, blood donors are paid, in others, they are not. In some countries, you have hybrid systems where, for example, whole blood donors don't receive payments or incentives while plasma donors do. And they can donate often and regularly and receive 25 euros every donation, so it can sum up to quite an amount. There's also, in the US, for example, there's lotteries and raffles, so you can participate in a lottery and you can win up to a car, even if you are a blood donor. So that's high value incentives. There's also gifts, high value gifts, in some countries and services, tax reductions, or time off work. Also an interesting and high value incentive because someone has to pay for the time off work. So we wondered, do incentives work? And we know from, for example, from studies about behavioral change, for example, stop smoking or vaccine uptake, that incentives can work, but the behavior is beneficial for yourself, for the individual. So if you stop smoking, it's better for your health. If you take the vaccine, it might be better for your health as well. And their incentives, especially financial incentives, have proven to work, especially on the short run. So the long-term effects are less clear. But for blood donation or other types of pro-social behavior, where your behavioral change benefits someone else, there's way more inconsistency in the effects of incentives. So we wondered whether we could try and explain part of this variation, and we come with a cultural explanation, and so that's in this case social norms. And what we mean with social norms is whether incentives, and especially high-value incentives, are deemed acceptable by the population or by society. So if you have a history in a country of paying blood donors, the social norm might be, yeah, we pay blood donors. It's what we do. It's normal. It's acceptable. It's right. Then maybe it works better than in countries where it's not common. So people might think, no, but this should be an altruistic behavior. It's not good or right to pay. So we thought maybe this might help us to explain this inconsistent effects that we've been finding all over again. When you incentivize pro-social behavior, sometimes it works, sometimes it doesn't, sometimes it backfires. It works for different demographics, not for others. So before we try to explain or predict the outcomes of donation with incentives, we took stock of the incentive landscape across Europe. And what you can see here is on the left map, you see countries where financial incentives are offered to blood donors. In the yellow ones, all blood operators do pay donations. In the green country, which is Germany, it's a hybrid system. Some operators do, some others don't. On the right map, you see time incentives. So that means time of work. And that can range from, for the very blood donation, you get time off from work, but it can go up to 2 days in certain countries. That's a lot, right? 2 days of work for blood donation is a high value incentive. So we see quite some variation here. And we then wonder if this also predicts the rates of blood donations in these specific countries. So again, we use large-scale survey, comparative survey data from the Eurobarometer, and we ask people about their blood donation history, about their motives to donate, whether they are intrinsic or extrinsic, so want to help people or receive something in return, such as financial compensation or time. And then we try to, or we operationalize social norms with how much accepted providing incentives is in the specific country. So we ask people, do you deem it acceptable to receive time or blood, cash or vouchers or for making a blood donation? And then we also know, as I have showed in the previous slide with the maps, we know what countries do, what types of policies they have in terms of incentives they offer to their donors. And so we try to predict outcome blood donation rates on receiving incentives and social norms. So we've seen that. This is the variation in incentives that are offered in these countries. And in this map, you see the social norms. So here you see on the left-hand side, the proportion of the general population that deems receiving financial incentives for blood donation as acceptable. And in countries such as Spain or France is low 10%, and it can go up to 30% in Eastern European countries. So there, people have a more positive social norms towards incentivizing blood donation. On the right-hand side, you see the same map with regards to time incentives. So whether the general population thinks it's acceptable to give donors time off from work for making a donation. And here again, you see large variation, but a less clear pattern in terms of East-West divide. It's more scattered and more variation. And then we look how blood donation is associated with different motives and with these social norms. And what we find here is that still altruistic motivations predict blood donation. So whether people have a donor status, have been donors, and financial incentives themselves do not predict blood donation, but social norms regarding financial incentives and time incentives do. So that means we find an interaction effect. Here you can see it, that, for example, the probability that someone is a blood donor is higher when the social norm regarding incentives is high and the incentive is offered. So if you receive time off from work and the general population thinks this is acceptable, you have a higher probability to be a blood donor and make a donation. So incentives can work, but they might backfire if the social norm is against the policy. So that's, I think, something to remember and consider. So, and in a next study, because we as sociologists, we also want to look at macro effects. So just the last study I presented was more on institutional effects, right, on what blood banks do. But more generally, we were also interested in how countries, for example, organize their healthcare systems and how they incorporate blood donation in their healthcare systems, and whether this might also play a role in motivating people to donate. And here we extend our sample to a global sample. So the previous studies were in Europe. This one is now a global sample because, again, there's a large variation in donor rates across the world. In some countries, it's lower and higher, and 40% of the collected blood globally comes from high-income countries. And as I said, in lower and middle-income countries, there's a family replacement system often in place. And this comes with the infrastructure that is limited in these countries. So there's no general blood operators or no Red Cross or Red Crescent organizations that do have all the infrastructure in place. So if you need a blood transfusion, you go to the hospital and you have to bring your donor to fill the stocks again. Otherwise, you're not treated. So large variation in system, large variation in also donation rates, and of course, large variations in healthcare quality. And because we have seen before that people say, I trust the healthcare system, and that also motivates me to make a donation, we wondered how the quality of the healthcare system in general might play a role in donor motivations. So, as I said, we take a global sample, 171 countries from the WHO States Report on Blood Safety and Availability. And then this is a macro study, so we look at donation rates in a country, and we look at the healthcare system and try to see an association there. So we take blood donation rates as an outcome, as ratio per 1,000 inhabitants. And then we look at healthcare quality indicators, and we have 2 indicators there. How much countries spend on healthcare as a portion of their GDP, and then healthcare access and quality. And this is a composite index that's comparable across countries, and it is about how many deaths could have been amended if timely and effective healthcare were in place in these countries. So the higher the system, or the higher the index, the more death could have been prevented. And here we see a very strong and very clear correlation that the higher the healthcare quality is in a country, the higher also the donation rates are. So investing in healthcare quality and infrastructure might also increase your donation rates. And I mean, this is maybe quite an obvious association, but still, it's interesting to see how strong it is and how clear it is. The higher the quality, the higher the donation rates. And we've done another study I will not show here, but it's also about trust. So it's not only the objective indicators for healthcare quality, but also how much people trust in the healthcare systems. So to conclude this piece about blood donation, we have seen individual factors, on the personal level, like motives and knowing someone else play a role, but also on the more institutional level, incentives can work, but only if the social norms are accordingly. And sometimes they can backfire because if the people think it's not acceptable to pay, then it will not work. So different levels and different factors on these different levels might influence blood donation and donation rates. So so far about blood donation, and now this is my new love, organ donation. I got very intrigued with this topic lately. So I'm working on a study currently on blood donation. And just to give you a bit of a background, how organ donation, there's long waiting lists. There's a limited availability of organ transplants, and there's many patients who wait for an organ. And these are just some numbers from the US to give you an idea. There's 90,000 people were waiting for kidney, and only 27% received one in that specific year. And 66% didn't receive one, and 7% died while on the waiting list. And I show you some UK numbers later on. They are comparable. So there's limited availability and high demand of organ transplants. And then if limited availability and high demand, politicians and policymakers think about interventions, how to increase the availability, and they often think that, for example, an opt-out system might be a solution to the problem. And the UK recently switched from an opt-in to an opt-out organ donation system. And an opt-out system means that everybody who turns 18 is by default an organ donor, unless you actively refuse to be one. And then you have to actively deregister or from the list or register on the list that you don't want to donate. While in opt-in countries, you have to actively say and register that you want to donate. So the idea is maybe nice because everybody's a donor by default unless you indicate otherwise. And research also shows that this increases the availability of diseased organ transplants, but the research also has largely omitted looking into related behaviors, such as, for example, living organ donation. And in the case of kidney transplantations, up to 50% of the transplanted kidneys come from living donors. Often family, often acquaintances, but also there's also altruistic donors who donate a kidney for a stranger. Especially in the Netherlands, this quite a high proportion of the living donations that are made by altruistic donors. So interesting, and we see that the waiting lists in these countries that switch to opt-out, they remain long. So even though you have the opt-out now, everybody's a donor by default, and you have more availability of diseased organs, the transplantation or the waiting list remain long. And so we wondered why that is. And we think this might have to do with a decrease in living organ donations. So we set out to answer these questions. What does switching to opt-out mean for both deceased and living organ donation? And why would we see a decrease in living organ donations? And which donors and recipients are affected most? So you could imagine that people who have a loved one who needs a kidney would always donate it, no matter what the consent system is. But for altruistic donations, that might matter, because you could think, oh, when everybody's a donor by default, I don't have to make this living donation because there's enough supply availability. So we formulated, this is really ongoing work, so we formulated several hypotheses. So we think that switching to an opt-out policy does increase diseased organs, but decrease living transplants. That this is the mechanisms we want to study is the supply sufficiency. So people in opt-out systems think, oh yeah, there's enough availability because everybody's a donor by default, and also the reduced reputation potential. And as I showed you at the beginning, increasing your image by making a donation is also one of the motives that have been discussed and have been shown in the literature. And this is, of course, something that's strong for organ donation and might be perceived as limited in an opt-out system. Because again, people might think, everybody's a donor, so it's not that big thing anymore. And then we think, as I said before, that the drop will be mainly driven by a reduced availability of altruistic donations, because the donating for a loved one, for your spouse, for your child, for your parents will still be something independent of the system. And we also think that people who have a pre-existing history of altruism will be affected most, because the altruistic potential and the potential of contribution is reduced. So we ran several studies here. We start out with a more epidemiological comparison, where we look at countries who did make the switch from the opt-out to the opt-out system, and we compare them to a series of countries who stayed within the opt-in system. We employ a quasi-experimental design called difference in differences. This means that you compare a set of countries, in this case, that made the switch from before and after to a group of countries that remain stable in their consent system, and you compare deceased and living availability of transplants. So we take data from the secondary data from the International Registry on Organ Donation and Transplantation, and also NHSBT reports. During the last couple of years, many countries have switched from opt-in to opt-out, or several. So we have 8 countries who made the switch between 2009 and 2019. We stopped at 2019 because then the pandemic came and everything was a bit derailed, and the trends weren't clear at all anymore. So we have this 10-year window, and we include 8 countries who made the switch and compare them to 27 of control countries that stayed within an opt-in system. This is an overview of the countries we have. So the purple ones have the opt-in system, where you have to give explicit consent of being a donor. The green ones have the opt-out system. So there you are by default a donor unless you deregister. And then there's some countries where it's not clear yet, or hasn't been clear by that time. And so we compare, you saw them on the right-hand side. We have these countries who made the switch, and we compare them to a series of other countries. And that's what we find. So on the panel A, you see the effect of deceased on deceased donors, and the dashed line here in the middle is the time of the switch, and then you go back in years relative to the switch, and in years after the switch, and you see that indeed the availability of the deceased transplants goes up, while the availability of living donations go down after the switch. So this is before the switch and after they go down. And on the panel C, you see the average effect. So you have an increase of 18% of the deceased organ availability and a large decrease in living donations, which comes down to a more or less net zero effect. So how can we explain this drop in living donations? What mechanisms might be behind? So here we do a cross-country comparison between Germany and Austria because they are culturally similar countries. They have the same language, and Germany has always had an opt-in system, while Austria has an opt-out organ donation system for many years already. And here we compare. We ask people about their willingness to make a living donation for various recipients. So for a loved one, for a close relative, for a friend, for an acquaintance, and for a complete stranger. And we also collect some information about supply sufficiency, so whether people trust that others donate or there's enough availability, and the reputation building potential by making a living donation as a heroic act, so to say. And what we find is, interestingly, that indeed there's not so much difference in willingness to make a donation to a core family member, and while to a stranger there is a difference. And in Austria, people are less willing to donate to a stranger in an opt-out system compared to Germany, where people are more willing to donate to strangers on an opt-in system. And also what we see is that the willingness to make a donation for a core family is generally higher or high than compared to a stranger, which makes sense, right? You want to save your family or your loved one, and the costs for making a living donation to a stranger are high. The mediators we are interested in, or the mechanisms behind the effects, here we see differences again. So the reputation building, the potential that people think they can increase their image and their reputation is higher in the opt-in Germany than it is compared in Austria with the opt-out system, while for trust it's the other way around. In an opt-out country, people perceive the availability or the supply higher compared to an opt-in country. And indeed, we find that our underlying mechanisms might partly explain this, because we find a partial mediation between the opt-out policy and the decrease in reputation building, the increase in availability, and then the effect on willingness to donate in the end. And then in the last study, we do an experimental approach. Again, we take samples from Germany and Austria, but here we manipulate the situation, or we show them, we provide them with a hypothetical situation where we say, imagine you live in an opt-in country with a registration rate such and such. How would this influence your willingness? So we do a 2x2 between subjects design. We vary the default system and the registration rates, and again we collect the same measures: willingness to donate to different recipients, trust in the supply sufficiency, and in the potential for reputation building. And we also look at altruistic behaviors people have been doing before, like helping strangers on the bus, or making a charitable donation to a good cause, or there's several of these behaviors. And interestingly, we find a very, very similar picture. So here we have blue is the opt-in policy, which assumes a lower registration rate because everybody has to actively make their decision known on the registry. And we see no difference in willingness to donate to a core family member, while to a stranger there is a difference, and the willingness is higher in opt-in compared to opt-out countries. And again, the trust is high. The trust in availability and supply sufficiency is higher in the opt-out country because of the default, everybody's a donor. And now we were interested in how much this affects the donors, because we have seen the recipients, mostly the strangers are affected, while the core family member, there's not much of a difference. And here we see that indeed the high altruists are affected the most. So because the potential for being altruistic is reduced, or at least is perceived as reduced in these settings. So to sum up, yes, opt-out defaults do result in more diseased organ availability, but they might backfire in terms of living donations and reduce the number. The perceived supply sufficiency might partly explain this reduction. So it is important to remember that policy interventions might backfire. We have seen that with the incentives and the social norms, and here again, so related behaviors might be affected by the intervention. And to just show some UK numbers, recent UK numbers. Here again, it's similar. There's many patients waiting for transplant. This is data from March 2023 to March 2024, released by the NHSPT. So high number of patients is waiting. It's even increasing the number compared to the previous year. Many people are temporarily suspended from the list because they're too ill to be on the list, because the outcomes are too unsecure. Here, people die on the list while waiting. There's a decrease, so that's positive, I think. And then some people are also removed from the list for good because they can just deteriorated too much, and they probably, that's what the report says, have died shortly afterwards. And when it comes to donors, we see that there was an increase in total number of deceased donors. So that's positive. And this was driven by an increase in donors after circulatory death, while the donors after brain death have remained stable. We have seen a small decrease in living donations, and the living donations make up to 38% of the total number of donors. So this is quite a significant number, right? So I wanted to, this were the studies I wanted to present to you, and I wanted to end with a short discussion, or ask you to consider some of the ethical aspects that come with all these donations, because I think making a donation, and that's also why I called my talk To Give or Not to Give, comes with interesting implications or considerations, and especially when it comes to living organ donation, there's dependency between the donor and the recipient. There might be coercion for family members to become a donor, even though they might not want it, or they are anxious, but they feel pressure. So how does an opt-out system affect autonomy? Because some people might not be able to make an autonomous decision because they are disabled, or they are not able to think this through, or they cannot make up their minds, and now they are registered as donors by default. So this can also come with great inequalities, because there's a shortage, for example, of ethnic minority donors in the blood donor pool, but also in the organ and stem cell donor pool. So patients with ethnic minority background have less access to healthcare compared to people with a majority background. And then I'm also recently getting very interested in xenotransplantation, because this is something that biomedical sciences have been working on a lot. So there's been experiments with pig hearts as transplants. But for me, as a more behavioral and social scientist, then I start getting very interested in, would people accept such a graft? What would that mean? Could you breed pigs to become donors? Is that ethical? So these kinds of discussions I'm very interested in, and I hope that you will have some questions or thoughts about that. And so with these considerations, I can show the slide again, but I want to end with some acknowledgements. So thank you again very much for inviting me. And I also acknowledge my wonderful research groups, both at Sanquin and at the university, because without them, I could not do all this work. So I'm very grateful to them and to you for showing up and to listening. Thank you very much.
Thanks. That was a great overview of blood donors, organization, incentives, and behavioral science. We have time for a few questions. I'll maybe start with one. So you mentioned about the blood donation, organ donation. You omitted plasma donation.
Yeah.
Any consideration on that in terms of incentive? We know that as a European, we rely a lot on the US plasma production. That is actually provide incentive, pay incentive. What's your thought about it?
Yeah, I think that's an intriguing question. And as we discussed previously, we will have to see how much plasma we can still import from the US because of the new administration there. And also because the European Union, they have released the new guidelines last year on SOHO donation, blood and plasma and organ donation, and they strongly encourage and advocate for non-remunerated donation. But we are not self-sufficient in the plasma supply in almost all European countries. So the only countries that are self-sufficient are the ones who pay their plasma donors. But still, it is a very complex field because of international and European exchange programs and laws. So not the plasma that we collect in the Netherlands, for example, does not necessarily go to Dutch patients because there's like big pharma is involved and some medicines are produced somewhere and go elsewhere and the other way around. So I think this is a very complex topic. And I think the interesting question here is we need to talk about remuneration in a more open and less sentimental way, I think, because remuneration can work. It should not be, I think you should not pay donors to be able to make a living from their donation, but compensation of some of the efforts, why not? If it's, if it's organized in a certain way. I think these are all questions that we should discuss in an open way, but also address empirically. So what would work, what wouldn't, and how?
I guess you're showing that, for example, in blood donation, there are already incentives that sometimes could be considered pay incentive, day off and so on.
Yeah.
Not that different from being.
No, but it is interesting because people perceive it differently, right? You saw that on the heat maps. Like, time incentives are perceived as less financial or less, maybe also less coercive than financial ones, while you can argue that they are very expensive for the state, for the employer. And what does that mean? So I think there's many questions that we still need to answer.
Or I think I should leave more for the non-vegetarian disease. As I'm working in the area of the safety of donation with my first of all, whether the cultural background donors will change their perceptions toward their social norms and that. Because thinking, for example, I have immigrated from, I guess, a country where donation is often remunerated, or for example, family placement, to a country where obviously now it's not. So how did that change people's perceptions of either their motivations, but also their perceptions of remuneration of whether it should be?
Yeah. Yeah, thanks. Great question. I think it's a very important aspect because I'm guilty of it as well, but many studies talk about the donor, but the donor doesn't exist, right? People come with histories, with families, with different considerations, different motives, different experiences, different anxieties. So this all influences their behavior. And we so far we try to also design campaigns and interventions that that address as many people as possible. But I think when it comes to recruiting ethnic minority donors, where we do have a shortage in many countries, you have to design more specific and more targeted interventions and address different aspects than compared to other demographics. For example, trust in the system, or also associations with blood that can be very different in different, for example, religious backgrounds. Blood can be sacred, or sometimes it's, there's more spiritual things around it. And then also it comes to maybe language barriers or access to certain collective sites. So I think this all influences people's intentions, and in the end also their behavior, and we should take this more into consideration.
I was the second very small question. I was curious about, so right now in the UK, people don't provide easy read documents to explain the process of donation. People, for example, if they have learning difficulties or they can't understand the standard consent form. So I'm wondering, what do you think are the implications of, for example, having those things available to people? So I think people can actually, there's this ethical question, can they understand?
No, I think that's a very important issue. For example, we start now to try and make all materials available in B1 level language, so lower level, or low is not the right word, but easier to understand. And also what we have a study we are running currently about patient how patients can get more involved into certain therapy decisions. And we also read the material, or we record and play it, an audio to get them, make it read to them, so they don't have to read it themselves, because sometimes there's a lot to read and it's complex material. So we record it in B1 language level, and hope that this makes it more accessible for a broader group of either donors or patients.
Thank you for your talk, and I'm very interested in your fraction analysis based on the incentive and the blood donors. And I'm wondering whether you're going to independent analysis or stratified analysis based on the donors and non-donors, because intuitively I think the non-donors and the proportion of people knowing the policy could differ largely between the non-donors and the donors, and the ones from non-donors may reflect better about the public advertisement of the policy.
Yeah, I think you're right. It's also because the proportion of the non-donors is bigger, and the one of the donors is smaller. And so we ask not about the policy itself, but about the acceptability of, like a hypothetical question. But I think you're right. The way it is organized in the country might be more known to donors. Yeah, that's true. Thank you.
Yeah, I had a question really interesting about the financial incentives, the anti-social element about the financial incentives in some countries compared to other countries. And you know, it's potentially related to the health system. Like, for example, in the UK, the NHS is free, so healthcare isn't really paid for, and maybe some other countries it's not free, and how that potentially impacts the social norm.
Yeah, no, I think this is an important aspect. I haven't said that, but you see, for the financial incentives, you saw a bit of a East-West divide, and in Eastern countries, for example, you have these types of financial incentives that you have free access to healthcare, or reductions on medicines, and this goes together with healthcare is not necessarily free in all these countries. So yes, this plays an important role.
It's about the organ donations. I was quite it's very interesting to see that those countries that switch from opt-in to opt-out, you can see an increase in deceased donation and a decrease in living donation. If a country comes to you and say, should we transition from opt-in to opt-out, would you say yes, no point, or no, and why?
Yeah, that's a tough question.
So my analysis is that for the people that are cremating because they're diseased, there are not going to be any consequences on them, whereas the living donors, there might be.
Yeah.
So that's on the donor side, it's better. but is it looking better on for the person who's receiving the donation as well?
Yeah, I think there's several aspects here we need to consider. Receiving a living transplant has better outcomes for the patient in terms of morbidity and mortality. So patients have longer survival rates with a living transplant compared to a deceased transplant, compared to dialysis, for example, in the case of kidney disease. So that's one aspect. The other aspect is most patients on the waiting list wait for kidney, but other patients are there as well, right? So, and the most living donations are for kidneys because the family donations. So if you go to opt out, you have more deceased transplants, so you might have more dead hearts for the heart patients, but you might have less kidneys for the kidney patients. So it and we don't really know what the numbers look like, because we now look at kidney mainly because most of the living kidneys or the living transplantations are kidneys, but other transplants like hearts or pancreas or liver is the other organ that you can also donate living, a part of your liver, a lobe of your liver. Very invasive and very long recovery. So even maybe a more difficult decision to donate a living compared to a kidney, but for deceased donors, there's no consequences, but there's for the family. So I think that the third aspect that plays an important role is education and professionalization of the transplant team to also get the families involved, because what we see, and I don't know the numbers by heart, but interestingly, so even though in an opt-in system, what we had in the Netherlands until 2020, if people have actively registered as donor on the list and they die, and this is known, still families sometimes say no, because, you know, all these countries have so-called soft systems, either opt-in or opt-out, so the family has the last word. And I think there's also a lot to gain in terms of education, in terms of facilitating dialogue, in terms of removing a bit of the death taboo, because it's hard to talk about dying and what happens when I'm not there anymore. But for the donation topic, it's crucial because and you know, and then there's the rush, because if a patient dies, the organ will not survive forever. So people have to make this decision very quickly. So I think there's a lot also we need to invest in professionalization of the transplant nurses and how they ask and talk to family, how families involved, how many, how much, when, at what moment.
Or you could be part of the primary school curriculum and so to teach children.
No, I think
What transplantation.
No, I think we just finished a commentary on implementing education, maybe not in primary schools, we have, but schools in general, about donation, right? Because one of the most often barriers that you hear from people when you ask them, have you ever considered donating blood? They say, I didn't even know it was necessary. So the awareness of need, or the knowledge that this is possible, that you can go to a blood bank and donate, that there's collection sites, maybe very close by. So these aspects, I think we should implement in the curriculum, just to make kids aware.
Actually, in the UK, sorry to jump in, there is now a very new A-level like system, and also GCS. So across the kind of the older ages, I think above 10, there's very new curriculum.
I know. Yeah, so I've been in contact with some people at the NHS that do that, and they say it's too early to evaluate it, but it is very interesting because in Europe, the UK is the only country. Portugal is considering it, all other countries don't have it. So in many countries, blood collection institutes, or maybe also organ transplantation societies, they have like these packages for guest lessons, for example, or so you can hire someone from Sanquin to give a lesson to the kids, but it's not part of the compulsory general curriculum, and that might work. But it's, of course, you know, if I talk to some teachers and they say, oh, but our curriculum is packed, and there's so many good initiatives, and not so many, you know, climate change, or I don't know, health behavior. So yeah, I think it will be hard, but I like that the UK started it.
just time for last question.
Maybe also, yeah, give the people on, I don't know.
Are
if
there
there's
any
online.
questions online?
No, sorry.
Oh, no. Okay, awesome. Perfect.
I think that's just last question.
Okay, I don't know if it's a quick question on
We'll see.
the black market
Oh.
of organ donation and how that impacts things.
Yeah. I don't know. I haven't even started looking into that because it's just such a big topic. So I think this plays an important role because sometimes receiving a transplant is for the rich only. And that's, of course, a problem, especially when you look at moral and ethical aspects, but I don't know anything about it.
Well, thanks again. Thanks for
My
thanks
pleasure.
for coming.
Thank you.